moment to introduce our speaker, Dr. Bonnie.
Great. Thank you so much, Benita, for the opportunity to launch this 33rd webinar. And thank you for the very detailed introductions. It's great to see you all. It looks like we have about 40 participants. I especially want to thank Dr. Bonnie Kaiser. It is currently about 5 a.m. in the morning. So speaking to 40 people at 5 a.m. shows her true dedication. I know Bonnie quite well. I've seen her throughout her career and her development, and I just want to say to you all, this is going to be a real treat. In Nepali terms, I would call her the Maharani of qualitative research. So she's the queen of qualitative, and has just done so many impressive things. In terms of her formal biography, Bonnie Kaiser is an associate professor at the University of California, San Diego, and she has a joint appointment in both anthropology, in which she holds her PhD, and global health. She's a qualitative and mixed methods specialist extraordinaire. Her training was done at Emory University with a PhD in anthropology and a master's in public health and epidemiology. And she went on to Duke Global Health Institute, where she did a postdoc in global health implementation science. Her anthropology research focuses on elucidating cultural models of mental health and illness and exploring the connections to care seeking, developing and adapting measurement tools for cross-cultural research and interventions, for which she just, in collaboration with TPO, received an award from WHO for developing some new translation materials. She also works on improving cultural adaptation of global mental health interventions, and she critically explores the cultural concepts of trauma, risk, and resilience. Her implementation science projects focus on mental health, oncofertility, which is fertility preservation among cancer patients, and other areas of healthcare access. Her research includes deep ethnographic engagement in her primary field site of Haiti and mixed methods and multi-site research in other global regions, including Kenya, Nepal, Ethiopia, Nigeria, and the United States. And I'm very excited because today we'll be hearing a lot about best practices in rigorous qualitative. I think all of us on the call do some form of qualitative work, but in terms of understanding really the best practices, there's no individual better suited than Bonnie to be able to share that with us. So with that, I'll turn it back over to you, Benita, and then Bonnie will be able to start. Oh, Benita, you're still muted.
Oh, so sorry for that. Yeah, thank you, Brandon. And I'm also excited to hear from Bonnie related to the qualitative data analysis. So you can share your screen, Bonnie, and the floor is yours.
Thank you so much. Thank you for the very generous introduction. Good evening to you all. Good morning from California. I'm going to actually switch my camera so that I am looking at y'all as I'm looking at my slides. So I'm going to give an overview about qualitative data analysis, and I'm going to try not to get too excited and talk really fast, but if I do, just kind of put in the chat like, hey, could you slow down a little bit? So I'm going to give a few examples of application to global mental health research. So I will talk about some projects in Nepal, and I have some examples also from my work in Haiti if there's time to get to those as well. Yeah, feel free to I have the chat open. So if you have any clarification questions while I'm going, feel free to put those in the chat. And also that, like Benita said, there's time for discussion at the end as well. So I wanted to start by just kind of situating where like my career trajectory, I guess, and where I've worked. So as Brandon mentioned, Haiti is my main field site, and I worked there starting in my graduate school training. So it's been about 15 years. And I have done very exploratory work studying mental health and care seeking in Haiti and working with Zami La Santé or Partners in Health as they kind of developed their mental health care programming. I then did a postdoc with Brandon and worked in Nepal on Reshape, which some of y'all are familiar with, and we'll talk a little bit about it later on in the webinar. But this was a project focused on engaging service users in training of primary care providers as a way to reduce stigma of those providers towards kind of providing mental health care. We also worked on that a similar project in Ethiopia. I've worked in Nigeria on a couple of projects related to adapting and validating mental health measurement tools for kids. So culturally kind of appropriate ways to identify folks who are in need of care. And then I've worked in Kenya on a project that was actually a family therapy intervention and delivered by kind of non-professional lay counselors, and really making sure that that was culturally appropriate. So I just wanted to give you a bit of the kind of arc of my work. I should probably have one of these markers in the US and talk a little bit about my research there. So I'm going to start with just a couple slides about qualitative research broadly before getting into qualitative analysis specifically. This is talking about methods like interviews, focus group discussions, but there are a lot more methods. These are the main two that we tend to include or mean when we're talking about qualitative research. So it's primarily exploratory, open-ended, trying to understand people's perceptions, their experiences, the meaning that they attribute to different experiences, asking kind of questions or providing insight about how, why. Those are the kinds of research questions that we answer with qualitative research, understanding processes for how things happen, and the kind of data that we get. So as opposed to quantitative data, which is usually numbers, qualitative data is usually narrative, open-ended kind of transcripts. So an interview transcript, for example. Quantitative data usually very focused, specific information. If you think about like a closed-ended survey, each question is factual, focused, in contrast, qualitative data is very expansive. It's very detailed. Quantitative data collection is very structured, ordered. Qualitative can be very flexible, very unstructured. And then our kinds of questions we're trying to answer with quantitative data tend to be counting, quantification, associations. Qualitative data, the analysis is about identifying themes, describing those themes, categorizing them. So that's what most of today will be going into more detail about that. But I just wanted to kind of situate us a little bit, in the kind of data and the kind of research that we're talking about. Here's a few more kind of links to readings and videos to learn more if you're, interested in, but haven't kind of done a lot of training in qualitative research broadly. There's a lot of resources out there, so these are just a handful. And again, today I'm just going to be focusing on the analysis piece. So I'll give a really brief kind of overview of what the steps of qualitative data analysis are, and then I'll go into more detail about each of those steps. So generally what we start with, again, is a lot of open-ended narrative data. So think transcripts of interviews or focus group discussions. So like if you, record it in Zoom and it gives you the transcript of everything that was said, or maybe you have to do it by hand and it takes forever, but you have all your data. The first step is that you're reviewing your data to identify what themes are there. So in our mental health data, that might be, people talking about how they experience kind of mental illness or how they seek care for it. It might be related to experiences of care, positive and negative. Whatever those themes are that are in your data, you're first identifying those by reviewing your data. And then what you're doing is tagging those themes in your data. This is called coding, and we'll talk more about it. But this is just an image of what it might look like in a software package. You're just kind of going through and saying, here's that theme about experiences of, treatment. Here, it's here, you're literally just tagging everywhere that it comes up in your data. Here's that theme about care seeking. Here it is again, here it is again. So you're just going through and rigorously kind of marking where all of these themes are in your data. And then the kind of main step is that you say, okay, now I want to read everything about one theme. So it might be that theme about experiences of, receiving treatment. So this is an example in a software package. You can totally do this without software, but you'll say, I want to read all the data that I tagged for that theme about experiences of treatment. And you read all of that together. So all of the data that you have on that one theme, and you summarize the data. So that might be that you write, a half page or a page or more, just kind of summarizing what is in those data. What did people say in the interviews about their experiences with receiving treatment? So essentially what you're doing is going from, a lot of data, a lot of transcripts with a lot of detail on a lot of themes, and you're saying, here's a, one-page summary about this one theme, experiences of treatment, for example. So someone who wasn't part of your research could come along and read that one page and get a really nice understanding of that one theme in your data. So what you're doing is kind of condensing, from a lot of open-ended data to a nice kind of description of that theme. And then you repeat that for the other themes in your data. But this is essentially the basics of thematic analysis, which is to say, analyzing themes in your data. So I'm going to go through each of these steps in more detail, but I wanted to just start with that big picture, what the process looks like. So I'm going to talk about thematic analysis. This is kind of a fundamental approach to qualitative data analysis. There are a lot of different approaches, and you might hear a lot of terms out there about how to do qualitative data analysis. So I think thematic analysis is kind of a foundational approach. It basically means you're identifying themes in your and textual data, so like interview transcripts, and you first identify what those themes are, then you tag or code your data by theme. Your analysis involves description or summarizing of those themes, and also kind of looking for patterns, bringing in context. But basically, thematic analysis is identifying themes and summarizing themes in your data. So it's describing or summarizing those different themes that come up in your qualitative data. This is often a foundational approach that's used in other analytic approaches. So again, you might hear about grounded theory being used. You might hear about narrative analysis being used. Again, there are a lot of different terms and approaches to qualitative data analysis. And the same kind of basic strategies or tools that we'll talk about today can be applied in those as well. So code development and coding. This is kind of the core of what you do with your data and preparing your data so that you can write those nice summaries of the themes in your data. So what is a code? A code is essentially a theme. So, any of the issues or themes that are in your data that you've identified is a code, and you identify them by intensely reading and rereading and kind of taking notes as you're reading your data and saying, here are the themes that I'm seeing. And codes are really the tool that you use to label or tag your data set. Again, saying, here's where I'm seeing people talk about their experiences of receiving treatment. Here's where I see people talk about causes of distress. Here's where I see people talking about stigma. So those are all the codes, in your data, and you're just kind of coding is that process of tagging where they are, like where those themes are arising in your data. So for example, I've been mentioning these throughout, but if you have data on mental health, your interviews or whatever your data are may include codes on causes of distress, care-seeking behaviors, perceptions of treatment, stigma. So these are all themes that might arise, in a project on mental health experiences. So these are codes that we might create for our data. So I'm going to give one example from Reshape. And so some of y'all might be familiar with this. Some of you might have worked on this project. One of you developed this project. But I just wanted to kind of introduce it in case anyone's not familiar with it. So Reshape, like I mentioned earlier, is a project that's focused on stigma reduction among primary care providers who are being trained to deliver mental health care. And so it was actually compared to PRIME, which was a broader program across different countries to train primary care providers in delivering mental health care. So both PRIME and Reshape provided training in mental health diagnosis and treatment to primary care, both prescribers and non-prescribers in Nepal. And then Reshape had this additional aim of addressing stigma or reducing stigma by including service users, so people who are receiving mental health treatment, as part of the training of the providers. So I'm going to give some examples from the project from Reshape. And these examples are from interviews that were conducted with the providers after they went through the training. So these are folks, again, some are prescribers, some are non-prescribers, who participated in this training to deliver mental health care in their work. And, part of that training involved service users telling their recovery stories. So this is just an excerpt of an interview, and I'm going to read it, but I want you to think about, as I'm reading it, what themes you hear coming up in this one small section of an interview. So what codes you might create. So the interviewer asks, how do you feel like this training has helped in your work sphere? Respondent, when they recover or improve, we feel like we have done something wonderful by helping them. They express their gratitude for our hard work, and that makes us feel good. It makes us feel like we are doing something great. Interviewer, and sir, regarding patients with psychosocial problems, when it comes to your healing process and method, what changes do you see before and after the training? Respondent, I learned a lot of things. Things like how I shouldn't smirk or giggle and what they had to say. The major change that has happened to me before and after the training is that before the training, I would only refer. And now after the training, I have learned how to handle a case. Interviewer, sir, are there any problems or setbacks in health posts when it comes to helping a mental patient? Respondent, yes, it isn't easy, mostly because our society doesn't understand mental illness and that they are not ready to accept it yet. When you break it to someone that they are mentally ill, you have to be very careful. You have to choose your words very wisely. Interviewer, are there problems, setbacks in providing medicine and psychosocial help? Respondent, yes, there are problems. There isn't a designated place to sit and talk. This makes it hard to maintain privacy. When I'm breaking it down to someone about what illness they have, I have to deliver the news in front of everyone, and people may talk amongst themselves about what they hear about someone. We haven't really been able to maintain privacy. So I don't know if anyone wants to share in the chat, or you're welcome to unmute and share any themes that you see that you notice arising in this short section of an interview. Okay, so we have skill development as one of the themes. So the skills that the participant mentions developing in the training, lack of infrastructure and privacy, for sure. They're talking about some of the issues that they face in their health post. Stigma for sure is coming up a couple times. Great. Any other themes that y'all notice? Yeah, challenges to provide services for sure. So that includes kind of the confidentiality problems, but also, yeah, kind of other challenges. These are great. Okay, so this is the process that we use when we're identifying themes that we want to kind of turn into codes and do the coding of our data. We, do this with a whole section of our data set. So generally, when you're trying to develop your codes, which again is the same as saying identify themes in your data, you review about a third of your data, but that's just a rule of thumb or an estimate. So it's really just to say, this is usually how much you need, but it will vary. And I'll talk more about how you know more precisely when to stop. But what you want to do is review some of your data. And when I say some of your data, you want to select diverse transcripts because you want to make sure that you're getting at the variation in themes that exist in your data. So if I have data from interviews with some folks who are employed and some folks who are unemployed, and I have interviews with women and men, I don't want to only read, my interviews with employed women, for example, and none of the other data, because there might be variation in experiences across these different kinds of interviews. So I'm going to pick transcripts from each of those subcategories and make sure I'm seeing kind of a diverse cross set of like my data or my interviewees' experiences. So to develop your codes, you read and read and read your data to really get familiar with what's there, to identify the themes that are there. You get kind of sick of your data after a bit because you read it quite a lot. And as you're reading, you're writing what are called memos, which is kind of notes reflecting on what you're seeing. You might be thinking, okay, here's a potential theme. I have a question about this part of the data. I want to clarify. I wonder if this other subgroup feels the same way or has different experiences. You're writing these notes, like it just might be like notes in the margin, of your piece of paper or Word doc comments, however you want to write these notes, but you're just sort of reflecting on the data as you read it. And you use this process to develop initial codes, what we were just doing with that example activity. So you're reading the data, you're seeing some themes that are there, and you use that to develop a list of like, here are some themes in my data. And you're going to develop what are called code definitions, which is to say, what does that code mean? When I say stigma is a code or a theme in my data, how am I defining that? When I say, something about the kind of barriers or challenges with providing care, how do I define that code? And I'll say more about that. And then, you keep developing codes, you keep changing codes as well until saturation. So saturation is literally where you're like, I keep reading and I'm not seeing anything new. Everything that I see as themes in these data, I've seen before, it's on my code list already. The last transcript I read, I didn't see anything new. So that's the point where you can say, okay, I probably can stop reading new transcripts at this point. I can say that I'm finished with code development, which again is identifying codes in your data. And then what you'll do is you use that list of codes you've developed to kind of label or tag your entire data set. So again, you might end up using about a third of your data to develop codes. Again, that's just an estimate. You actually stop at saturation. And then you'll use those codes you've developed to code your entire data set. And so there that is visually. So I just wanted to show another visual about what I described saturation. So as you do interviews, your early interviews are giving you a lot of new themes. So a lot of new pieces of information, types of information are coming out of those early interviews because you're getting all kinds of things you haven't heard before. But then as you continue doing more interviews, things kind of slow down. And again, you're just hearing repetition of the same themes that you've already heard before. So you've saturated the themes. You've essentially you've identified all of them. As you do more interviews, you're not really adding any new information to your research project. So that's kind of the point where you say okay, we can stop doing more interviews or, in this case, we're talking about data analysis, you can kind of stop reviewing more transcripts, and move on, to the coding process. So I will note, this says waste of your time, which is tongue in cheek, but it's also potentially wasting participants' time to keep recruiting more people if you're not necessarily in need of more participants because you've already kind of identified the range of issues out there. So one important part of the coding process is making what's called a code book. And a code book is a list of what your codes are and your code definitions, which is more like instructions on how to apply your codes. This is helpful to make sure that you're consistent in applying your codes, whether that's like consistent with yourself over time or consistent across members of a team. So you want to make sure if multiple people are going through to read the data and apply the codes, which again is tagging, here's this theme, here's that theme. You want to make sure people are doing this process consistently or the same way as each other. So again, a code book has the name of each code and a clear description of each code. So this description would be information about when should I use each specific code, what type of text should I code, and what's excluded, under each code. And you usually in your description, you give examples of, text quotes that would fall under a certain code. Sometimes it feels like a code is obvious and doesn't need a description, but you'd be surprised how often people interpret something differently, like stigma. We all kind of know what that means, but we might have different ideas of like where the stigma code should or shouldn't be applied. So this is an example of a few of the codes from the Reshape project, the code book that was created from those interviews. So barriers and facilitators, which y'all identified in the activity that we did. So this was defined as any reference to either an obstacle that prevents the service users and the community to access service or treatment and the health workers to provide service or treatment, or something that facilitates the service users and community to access service or treatment and the health workers to provide service or treatment. It can range from things like human resources, attitudes, medication, communication, finance, structural, and organizational hurdles. For example, the patients here are from poor families. This is Chupan community. They have to travel to and from Bharatpur, which will cost a lot. So this is like the description to tell you the instructions of how to apply that code, barriers and facilitators. So medication is another code defined as any reference to medications, can be a description of healthcare workers prescribing or not prescribing medications, and or service users taking or not taking medications, along with beliefs, attitudes, and perceptions toward medication use, whether positive or negative. Can also include information learned about medication during the training. For example, one of the problems is that the service users do not take medication regularly. So we try to involve at least one family member in the treatment process and ask him or her to monitor that the service user is taking medication regularly. Stigma. So this one is a pretty abstract concept to try to come up with a definition or code definition, I mean. So personal or perceived threat to social status and or psychosocial well-being based on mental health condition. Common sources are ignorance, misinformation, prejudice, and discrimination, frequently characterized by shame or disgrace. Can also include reduction or lack of stigma towards mental health, frequently talked about as a barrier. So this is an instruction for applying the code stigma. It's saying that people often talk about that in the context of describing barriers to providing care. So that first code, barriers. So for example, my employer will treat me differently if they find out that I'm taking mental health medication and going for counseling. They will probably never trust me for important works, and maybe I will never get promoted. So there's a code changes before and after the training. So explicit self-assessments of change in attitude or behavior attributed specifically to the training could be referring to training as a whole or specific portions, can be positive or negative states. So for example, before training, I didn't treat mental health patients. Can also include reduction or lack of stigma towards mental health. For example, through my 10 years of work in health sector, I always thought that people with mental health issues cannot be treated. I used to avoid them as much as possible or refer them to Kathmandu the best. But now after the training, I've started to look at them differently and work with them. And one last one, mental health, a very broad code, any reference to mental health experiences, diagnosis, treatment, outcomes, etc. For example, we're working to push the government to prioritize mental health in its plans and allocate for budget for this sector. So this is just a handful of examples, and you'll have these slides afterwards to kind of see, here's how we defined each of these themes as like an instruction guide for people who are doing coding so that they know when to apply each of these codes to the data. So, now that we have our codes developed, we have our code book developed, we go through that process of coding, which again is just tagging where each of these themes arise in our data. This is not from Reshape data, but just to say, like, you might have your code book and then you're going through and reading your data. This is an example of doing it in software, and you're tagging where those themes arise. So we're going to do another example to just think about which codes from this short list I gave you would you apply to this excerpt, and kind of specifically where you would apply. So as I read this, just kind of think about, oh, I'm seeing stigma here, or oh, I'm seeing, barriers here. So the interviewer says, let us talk about the patients who came as facilitators in the trainings that you attended. So this is referring to the service users who were part of the training, and your experiences working with them before the training. Respondent, a very good question indeed. We got to learn so much about them because of the training. I learned that they too are normal people and could be very easy to deal with. They are not just crazy people as the society normally think. I learned all this during the training, and my attitude towards them has changed completely after the training. I had seen such before in the health post and wanted to talk to them, but they were not opening up. I think it is because they were too afraid to talk in front of a lot of people, and we do not have a separate confidential room in our small health post. What other difficulties do you have working with mental health patients? A lot. One thing is it is very difficult to have regular supply of medications in our health post. So when we have nothing to give to the service users when they come to us, it creates a very difficult situation. We are trying hard to address this. In the DPHO meeting last month, we asked our chief that mental health should be one of the priorities and should get as much importance as physical health. So if anyone feels like either unmuting and saying, hey, I see this theme in this section, or if you want to put in the chat, maybe the start of like the paragraph and what code you would say applies there. Okay, so paragraph 2. So a very good question indeed. This one we're seeing changes before and after the training. So this person's saying, we got to learn so much about the patients because of the training. I learned that they're normal people, etc. So they're talking about changes before and after. So barriers and facilitators was also mentioned. So I will say this third paragraph, I think it is because they were too afraid to talk in front of people. We do not have a separate confidential room. That's a barrier. So medications comes up in the last paragraph. One thing is very difficult to have regular supply of medications. So that theme medication would be applied. Mental health is also a theme that comes up specifically in that last paragraph about, mental health should be one of our priorities, should get as much importance as physical health. Great. I know this is harder to do like in the chat, but y'all are doing a great job of pointing out where these themes are coming up. And stigma, great. So third paragraph, they're too afraid to talk in front of a lot of people. So that's, referencing stigma. Also this paragraph, they're not just quote crazy people as the society normally thinks. I learned this during the training. So that's talking about stigma in the sense of, changing or reducing stigma. So great. So you can see like this is the process. We practiced code development or identifying themes by reading an earlier section of an interview. And now we're practicing applying codes by reading some text and seeing where we identify those codes. So this is what that whole process looks like of doing thematic analysis. We've identified the codes, we developed our code book. Now we're applying the codes to the data. So you would go, you would go through and do this with your whole data set. So all of your, in this case, interview transcripts. And then you move on to analytic strategies. And the main analytic strategy, or the main kind of task that you do to analyze your data, is called description. What that means is you're writing a description or writing a summary of each theme. So you want to make sure that your descriptions or your summaries cover both the breadth of issues. So what is the full variation of, how people talk about barriers and facilitators? What is the breadth of barriers? What are all the barriers they mentioned? But also give depth. So give detail about like, what do those barriers mean? So what does it mean that the health posts like don't have the infrastructure to, support mental health care? It means we don't have a separate room, so that interrupts confidentiality. It means we don't have medications, et cetera. So again, you're just creating a summary. In this case, if we're talking about the barriers and facilitators code, you're writing a summary of here's what came up under that code. Here's the range of barriers, the range of facilitators, and I'm going to give some detail or, some depth, some examples about what each of those means. So here's an example of a part of a code summary, not the whole thing, of a code called willingness to treat. So following the training, so this is a summary written by a researcher who has read through all of the code segments, so all of the places that the code willingness to treat was applied. Following the training, most providers expressed willingness or motivation to treat mental illness. They described that before the training, they were afraid to treat people with mental illness or would refer them. In contrast, after the training, providers expressed motivation, confidence, and enthusiasm for treating people with mental disorders. We had basic knowledge, but now the training has added more energy to work. And this is just saying that quote is from a prime trained prescriber. This is the interview code. Several interviewees mentioned specific individuals in their neighborhood whom they have or would like to talk to and treat, and one expressed interest in learning to counsel people who have attempted suicide. Several reasons were mentioned as leading to increased motivation. Some mentioned blah, 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 and the summary continues. After you do kind of a summary of one code, so, this willingness to treat code, the way the summary was developed is that you search in your data. This might be in software or it might be, by hand, for all the instances that you have applied the code willingness to treat. And so then you read all of those text segments or the portions of interviews where willingness to treat comes up as a theme, and you literally just summarize, those data. So here's all the stuff people said about willingness to treat. Then you might do a next step in analysis, which is called comparison. And this is just, as part of writing your code descriptions, or kind of a next step, is that you're looking for patterns in your data. And this is usually differences by subgroups. So for example, you might look at prescribers versus non-prescribers and how they talk about the reshaped training and kind of their experiences, how they talk about stigma reduction and barriers. Like, are there patterned differences between those subgroups? Are there pattern differences by gender, by employment status, whatever it might be in your data set as far as what those subgroups are. So again, you typically kind of do, a first summary of your theme, and then you kind of go through and specifically look for these comparisons, and you can add it into that summary. So for example, in this portion of a code summary I just showed you about willingness to treat, we can add in from our comparisons expressions of willingness to treat were more common among trainees from the reshape or the modified arm. So this is the training that involves service users, the majority of whom expressed a willingness to treat mental health patients. About half of interviewees from the prime, which is the original training arm, expressed willingness to treat. Willingness to treat was also somewhat more common among prescribers compared to non-prescribers. So we're literally looking through our data to ask, where are we seeing comparisons? Where are we seeing something that's, only talked about by one group, or it's talked about more often by one group, that kind of thing. And just to visualize these findings, so positive social contact with service users, which was part of the reshape training, reduced stigma overall. And so the standard training increased willingness to engage with patients about mental illness. So people were more likely to diagnose and initiate treatment. This is the providers were more likely to do that. So then they observed that patients were, improving. They had better quality of life because of treatment. That improves the provider's confidence in their own clinical ability. Then they have more willingness to engage, and it's kind of this feedback loop. And with the reshape arm, which is the enhanced training, what we see is basically this whole process is kind of amplified. So even more willingness to treat, then more treatment is actually being provided. They're seeing more patients get better, et cetera. So I'm going to stop here, I think, so that we can discuss. And I have some more kind of examples if they happen to seem useful to share in the discussion, but I will actually just show really quickly a reminder kind of about that overall process that we so just a reminder that we started with identifying themes and data. Then we talked about coding or tagging where those themes are in the data, reading all the data for one theme, and then developing a summary. So this is our overview of what the steps are in qualitative data analysis. So I just wanted to end on that.
Thank you, Bonnie. Wonderful presentation, and it's a pleasure to hear from you. Right topic at the right time. So, without taking time on this, let's move on to the Q&A. And Brandon, so Brandon will be facilitating the Q&A. Yeah.
Absolutely, happy to. So, Bonnie, thank you so much for that fantastic presentation. A couple of thoughts have come up in the question. So one, I know one of them, we've discussed a lot too. So what do you see as best practice around the quantification of data in qualitative research in terms of counting, like, oh, this theme came up 12 times, this theme came up 15 times. So talk about that and some of the debates behind it.
Yeah, so I will summarize as a lot of folks who come from a quantitative background and are doing qualitative research for the first time assume that the way you do qualitative data analysis is always to quantify qualitative data. And by that, I mean count, how often is this theme coming up? How often is that theme coming up? And so as you can see, that's not the main approach. The main approach is very descriptive. So summarizing, here's how people describe the theme, here's what it means to them or what it looks like. But there are certainly instances where the appropriate approach is quantifying qualitative data. The best way to answer the question is quantification. But I would say the main takeaway is that the analysis approach, so whether you're quantifying qualitative data or not, it just needs to match what your question is. So for example, one of my slides covers this, or one of my example slides covers this. So I'll just kind of open it up to give that example. So this was from a project in Haiti where people kind of told us because of beliefs about spirits, people won't seek mental health care at clinics. This is a really common thing. that we were told when we started working in Haiti. So we wanted to kind of see, is that true? And we used our data to answer the question. So first, we looked at, do people attribute mental illness to spirits in our data? And then also, where do they seek mental health care? So when we were trying to look at what are the most commonly cited causes of mental illness, we looked at all the text segments that we had coded for cause of mental illness, and we counted. So we quantified qualitative data. And what we found is that around 36% of the time, scent spirits were cited as a cause of mental illness. So most of the time, that was not what people said. And there was a whole host of different explanations that they would give instead. But that allowed us to kind of say, this expectation we were told wasn't true. It's not the case that, everyone says it's always caused by spirits.
Great, thanks. I'm trying to pick some of the more answerable ones. We only have a few minutes left. There's a lot of fantastic questions. Some of them I might, for those of you who put questions in the chat, they're very specific. So I might encourage you, if it's okay, to maybe email Bonnie specifically with those particular questions. Is that okay if they do that?
Yeah, and I'll put my email in the chat. It's bnkaiser@ucsd.edu.
Great, great.
So for the recording.
Yeah, and I can add it in too. So, oh, there it is, perfect. So I think a good one is this idea around deductive and inductive. So thoughts on doing it one way versus the other, and is combined aloud. And maybe just for folks, reminding them what the two differences are.
Yeah, for sure. And I would say most projects that I've worked on have used both deductive codes, which is to say codes that you kind of know of in advance, whether that's from literature, like we know stigma is going to be a theme in Reshape because the project is about stigma. We asked interview questions about stigma. So, deductive themes come from your own experience, the project design, the interview guide, again, from literature or theory. And then inductive codes are what arise out of the data. So as you're reviewing the data, like I described here, you identify codes. Now, even if you have deductive codes, so things that you're like aware in advance will probably be themes in your data, you still need to check, like, was this in fact a theme in my data? Because if, somehow you thought, I don't know, a certain issue was going to come up, in your data and it just didn't, it doesn't make sense to have that be a theme or a code. But I almost always have both deductive and inductive codes in my code books or in my data sets.
Great. And a really interesting question, Bonnie, how much do you use transcriptions that are more detailed, where people are kind of more of that literal, almost linguistic transcription, where they have pauses or the emotional reactions, or somebody laughs or they seem kind of sarcastic? But any thoughts on using that more detailed type of transcription?
Yeah, it depends on your goals. And I would say if you are really trying to do like a linguistic or narrative analysis where the way people are talking is really important to your research questions, or just otherwise, you think that level of detail is really going to be helpful for answering your research question, then it's kind of worth the time, because it will take time to have that level of detail. Sometimes you don't even need necessarily a verbatim word for word transcript. Like sometimes really detailed notes that you take in an interview might be enough. So again, it depends on your goals, for your project. If you have really, specific concrete goals that aren't necessarily, I want these rich descriptions of themes, but instead I just need to identify issues that I can then like develop a survey, and all I need is like a list of theme or a list of like, focused like topics for my survey questions, but I don't need this really descriptive, summary of themes. Like maybe you don't need a verbatim transcript in that case. So what you use as your data will really depend on your research goals.
And although folks haven't specifically asked this, I will take the liberty of throwing my own question in. From all the years working cross-culturally and globally and multi-site projects, maybe a little recommendations around the translation process and qualitative research when you get to the coding phase. Do you need the original? But what are your best practices around translation?
Yeah, whenever you can work with the original, language, I think that's great because, you're staying closest to the original form of the data. But there's all kinds of reasons that might not be feasible or kind of logistically, possible. For example, if some of the research team coders, don't speak that language. And so, in that case, what I typically try to do, is when I can have both like the original language and then the translation kind of immediately below it in my transcript so that I have them, kind of together and I can refer back to, kind of the original language. Again, this is like assuming that the person who's doing the research can, in fact, read both languages so that that's useful. Otherwise, I would just say having, obviously folks who are fluent, but also somewhat familiar with the research context, so that they understand certain terms best and how to translate them, have someone with that expertise do the translation. So ideally it's someone who's on the project, the research team. And then, maybe having a translation kind of checking process. All of this is like, there's trade-offs, right? It takes time, but as much as you have to kind of decide for your own project, kind of what works best or what makes the most sense. But I would say, like, if you do a project analysis in Nepali, but you want to publish your project in English, like, you can do the analysis process. And then just kind of pick like whatever it is that you're going to include as like example quotations in your article. You can just kind of translate those pieces of the data without necessarily needing to translate your entire data set. But again, if maybe there are all kinds of reasons you might do the translation earlier. So everything depends. In qualitative, that's always the answer. It depends.
Great. Well, thank you so much, Bonnie. This is just an absolute pleasure to have you join us. And you have just accomplished so much in this kind of mixed method space. So it's a pleasure always to work with you. Look forward to more of that. And I encourage anyone on the call to reach out. Bonnie's an incredible collaborator, incredible teacher. So we're all very lucky to have her with us today. Benita, let me turn it over to you to close out.
Yeah. I agree with Brandon. Thank you so much, both. So yeah, I must say that we really had an amazing discussion and engagement in this webinar as well. So I just want to say that we are really grateful to have you, Bunny, in this webinar. And thank you so much, Brandon, for your support. And apologies to everyone. So we had we have time limitations. So, but I ensured that I will connect with Bernie and share the questions and answers and share with you all with the feedback form and materials in your email. So see you in November. And thank you so much, everyone. Bye-bye.
Thank you all for having me.
And thank you so much.
Bye. Bye.
Bye.